Good morning, everyone. Yes, today we'll be focusing on the immune therapy in multiple myeloma. In particular, it has changed the landscape. We heard earlier today in the day we'll be focusing more on bispecifics. I like always to start with some facts. When it comes to myeloma, it is the second most common blood cancer in the US. There are 35,000 new cases annually, and survival has improved over the years. Now it's a 5-year survival of 61%, and myeloma accounts for just under 2% of all cancers in the world. And now we have these milestones, in all the drug approvals. As you can see, we have come a long way from the days of melphalan, although the drug that's very highly anti-myeloma activity, and we still use it in transplant till this day. But now with the introduction of all immune therapies, CAR-Ts and bispecifics, it really changed the landscape. I like always to start with some fun facts as well. That very first patient documented in myeloma was back in 1840, a London patient with bone pain and thick urine when heated. Don't ask why heated. And then the sample sent to Dr. Henry Binns Jones, so at St. George's Hospital, whose name still lives on in all lab reports till this day. So I like to share this slide every once in a while, but this rings true for this topic today. So, this is the single agent responses throughout the years, and we had such amazing time with novel therapies, but they really shine when in a combination treatment. But when it comes to immune therapy, and these are in the heavily pretreated population, this is unprecedented, where we see responses reaching 60% and above with bispecifics and CAR-Ts. This is something that has never been achieved with novel therapies, except in a combination, regimen. So, our majority of patients are becoming, triple class refractory quite early now. Now we used to have VRD transplant. Now we have DARA VRD transplant, and then patients, some of them are on DARA maintenance. Some of them they start DARA eventually in the second line with carfilzomib. So what does that tell you? You have now patients who are lenalidomide, carfilzomib, CD38 refractory patients. And we know from data now from the locomotion trial, those patients in real-world study, this looks at almost 250 patients. The median PFS for those patients is really abysmal at 4 months, and the survival of just above 1 year. And this has also been shown previously in the Mammoth trial, where triple class refractory, so triple class meaning PI, IMID, anti-CD38 refractory patients doing really bad. Penta-refractory is specific to the drugs carfilzomib, bortezomib, lenalidomide, pomalidomide, and anti-CD38. These particularly do very bad. In this analysis, those 35% of those triple-class refractory patients did not go on to receive new therapy. So why do we have this kind of relapse setting and refractoriness? So myeloma is a highly complex disease. And due to genomic events, but more importantly, there is an impact of therapy on the long-term outcome. What kind of impact? So look at the right-hand side here. So when you start with, with myeloma clones, you have different clones, but then you have this dominant clone and the small drug-resistant clone, that's the one in blue. And as it goes through subsequent therapies and treatments, that small drug-resistant clone expand and dominate eventually to become the more dominant clone. And that is the clonal selection and evolution. So, with this kind of therapeutic pressure, that leads to more drug-resistant and aggressive diseases. So what does the guidelines tell us in terms of how to approach these patients? Well, when it comes to these patients, what it tells us, whether triple-class refractory or pentaclass refractory is immunotherapy is probably the best approach for now, and BCMA-directed immunotherapy, whether CAR-T or bispecifics. And now we're in the immunotherapy era. We heard earlier today in the morning. With immunotherapy, what we mean by CAR-T cells, bispecific, and as well as antibody drug conjugates. We also touched on it in the morning. It's the belantamab mafodotin, which is making a comeback, by the way, and it's been approved just last week in the authority in the England drug authorities, but it's still under review in the FDA. So the BCMA target opened new vistas in myeloma care. BCMA is expressed in nearly all myeloma cells, and it's a B cell maturation antigen, and it's implicated in the disease proliferation and in the drug resistance. So I'm not going to dwell on this because we talked about it. We have now two CAR T therapies that have been approved, ide-cel and cilta-cel, and now that they have been moved into earlier lines of therapy with the KarMMa-3 and CARTITUDE-4, especially if you look at the CARTITUDE-4 long-term follow-up, the median follow-up at 33 months was around 60%, which is amazing compared to the standard of care, which was, for the most part, Darvarapom Dex, which came at 25% at 30 months PFS. So what about bispecifics, the topic of the day? So the best thing about bispecific is an off-the-shelf treatment. And now we have two targets that's been approved, BCMA, GPRC5D. Other targets are under investigation. The first of these drugs that's been touched on a little bit today, but we'll speak more in detail, is the teclistamab. The registrational trial was the phase 1/2 MAJESTIC trial. So these patients that were included were for 3 lines or more, have already received 3 lines or more. That included an IMiD, a proteasome inhibitor, and an anti-CD38. Quarter of those patients were high-risk cytogenetics. The median prior lines were 5 lines. So this is quite a heavily pretreated population. So of course you go through step-up dosing, requiring some hospitalization, then you go weekly dosing. Then if you achieve CR or better for 6 months or more, you go on for 2 bi-weekly dosing. So the results were impressive for this heavily pretreated population. So as you can see, overall responses of 63%, and more importantly, the VGPR or better, almost 60%, CRs of almost half of those patients, 46%. Not only that, if you respond fast. So the first response becomes after almost 1 month, and your best response is around 3 to 4 months thereafter. You have quite good number of patients achieving MRD negativity, around a quarter of those patients. And if you achieve a CR, half of those patients had MRD negativity. So even the overall responses was consistent across all clinically relevant high-risk subgroups. If you look at the penta-refractory, they kind of match the overall population, and as well as high-risk cytogenetics had very similar overall responses and very close CR rates. You know, EMD, extramedullary disease, a very difficult disease to treat. You still get good responses, but it's definitely still somewhat of an unmet need, but you still have 35% overall responses, 80% of those patients having CRs. So in terms of survival data, so teclistamab median duration increased to 24 months overall in that red curve, and was not reached for those in CR. So if you have a CR with teclistamab, you really do well. The PFS for the overall population was around 11 months, but if you achieve a CR, the median PFS was not reached. That is true also for survival, where it's not reached, but for the median overall survival for the whole cohort was around 22 months. And what about high-risk cohort PFS and survival? The data we have right now is at 6-month PFS, half of those patients were progression-free still, and at 6 months, there were 80% overall survival still. So of course, we all know about CRS and ICANS. CRS and teclistamab is for the most part in the step-up dosing. For the most part, is grade 1, 2, manageable. Grade 3s and 4 a little less so. When it comes to ICANS, you have 6% of patients ICANS. Again, for the most part, it's in the initial treatment dosing, but it's between step-up and initial treatment. For the most part, grade 1 and 2. Other areas of adverse events of interest, hepatotoxicity, we have seen this in clinic as well. Neutropenias, that's always significant with teclistamab, grade 1 and 2, but also have grade 3 and 4, half of those patients you treat with GCSF. You do have an infections and grade 3, 4, about 30% of those patients, and we're going to touch on how to approach those later on with IVIG and prophylaxis, but still manageable. The second drug that's been approved, the elranatamab, that's based on the MAGNETISM-3 study. So the MAGNETISM included patients who had been refractory to one of the 3 major classes of the drug. But interestingly here, they had 2 cohorts. one cohort who had received prior BCMA, and one cohort that did not receive BCMA, and then went on to receive elranatamab. Primary endpoint was overall response. So the overall responses achieved close to teclistamab, 61% overall responses, VGPR or better, 55%. Again, the benefit in this forest plot is across all subgroup benefit, even with the pentarefractory, although less than the overall population, but it's still touching at 50% overall responses. What about survival? So the PFS here is around, median PFS is around 17 months, and a median overall survival of 22 months in this also heavily pre-treated population. So they looked at real-world analysis of teclistamab response if they have received, BCMA-directed therapy. And of course, one of those being the antidrug conjugate, which is belantamab for the most part, or CAR-T. But if you look at CAR-T, which is the one that's being approved, you still have 57% response rates. And for the most part, it's still 40% or better, VGPR or better, in this patient population. And they noticed that those patients who respond to teclistamab in this cohort, who had a longer interval from their last BCMA treatment to the teclistamab. So the longer you have a space between one BCMA treatment and the other, the better chances of having a better response. But why do BCMA therapies, stop working? We have high response rates, but they're eventually going to progress and relapse. But why is that? So I like to call it, you run out of cars, you run out of gas, and you run out of roads. So meaning when, with persistence. So CAR-Ts don't persist all the time, so they do not survive. And there are reasons for this. It changes in the microenvironment. They get exhausted, so mechanically they're there, but they're no longer functioning well because of the prolonged activation of these T cells, which leads to exhaustion and reduced cytotoxicity. And expression, so there is a downregulation of the BCMA. So the hook of which the BCMA-directed therapy is clinging on is no longer there. So they literally have no roads to drive on. So, and this is usually because of some mutations altering that BMA structure. So what is beyond BCMA targets? So we know now that quad refractory, quad being the fourth class being BCMA refractory patients, having to do worse, really bad outcomes, a survival of median survival just 6 months. But then came the introduction of, talquetamab that it changed the equation. So this is the guideline right now in a quad refractory patient, where you consider talquetamab as your, priority therapy or another approach for anti-BCMA. So talquetamab is a GPRC5D bispecific antibody. It's been approved in 2023 in the US and the European Medical Agency. And it has been approved now in Saudi Arabia as of this month as well. So it's a GPRC5D CD3 bispecific antibody. It's highly expressed in myeloma cells. And it's a first-in-class kind of bispecific antibody as well. So the registrational trial of which it got approved was the Monumental 1. So the Monumental 1 had phase 1-2, and in the phase 2 they included, again, heavily treated population, 3 prior lines of therapy that included PI, IMEDs, anti-CD38, 3 patient cohorts that's dosing, that has different dosing, so 0.4 weekly, 0.8 bi-weekly, and then a cohort that had a prior T-cell redirected therapy. The primary endpoint was overall response with a multitude of secondary endpoints. So it achieved high overall responses across all subgroups and different dosing, including the once weekly and twice weekly, more CRs in the bi-weekly dosing. And in fact, the overall responses among high-risk subgroups was pronounced in high-risk cytogenetics and penta-class refractory, triple-class refractories in the 60s and in the 70s. So the generally consistent across all high-risk subgroups. So what about efficacy data and PFS? So if you look here, the median follow-up was 29, 23, 20 months respectively. And the median duration of response was highest in the bi-weekly regimen at 17 months. And the median PFS was 11 months in the bi-weekly compared to 7 months in the weekly regimen. So there was a better durability observed in the bi-weekly compared to the weekly. So, and that also, if you can see here on the right-hand side, the duration of response. Patients with deeper response. So if you have a CR like this in the red curve, you have obviously median duration of response that's much higher than those of VGPR or those with PR. So it does, GPRC5D, the target, is expressed in hair follicles and keratinizing tissue. And it's also, so it is normally expressed there. So expect side effects there. And that's what's been shown in the adverse event, emerging adverse events from the trial. So if you look at the CRS rate, as you might expect, 80%, mostly grade 1, 2. Dysquesia, which is the change in taste. Infections, of course, you expect some infections as well, mostly manageable, mostly in the grade 1, 2, some in grade 3, 4. And then you have the skin-related and nail-related infections, anywhere between 50 to 70% of those side effects. And also you have this kind of oral toxicity. Patients do not eat as well, and it causes weight loss. But that weight loss occurred early, but improved over time with longer-term follow-up. So patients eventually, regain better, taste and their appetite as well. Also talquetamab with extended follow-up, the safety compared to anti-BCMA was a bit better in terms of infection. It had lower infection rates and lower risk of severe infection rates relative to the BCMA-directed therapy. So it had much less grade 3, 4 compared to, teclistamab and belantamab. So some controversies with immune therapies is, what is the best therapeutic immune therapy? Is it an anti-drug conjugate? Is it an bispecific? Is it a CAR T? How do we sequence it now? And belantamab is coming back into the market. How does that change the algorithm with Dara up front now? Belantamab maybe in the first line, CAR T in the first line. So once the therapeutic has been utilized, what is next then? So this is a quick, collection of data from patients who had, different immune therapy exposure prior to a different immune therapy. The first three here, those is the ID cell, cell, and BCMA bispecific. These responses you can see ranging from anywhere between 70 to almost 100% with cell that had no prior BCMA. Well, what about the other way around? If you had some immune therapy prior and after, I'm not gonna go dwell into this, but you still get some response. It does drop a little bit. The PFS does drop a little bit, but it still works. The concept is there. The probability is you better have some kind of spacing prior to starting a treatment. Again, this is numbers are too small. This is not randomized. I'm not powered to look into this. So there is no perfect sequence. There are multifactorial factors to, that influence your choice of sequence in therapy. And so what does this mean? In general, this is my principle. The BCMA targets we saw earlier, it does not easily lose, it comes back. So unlike CD38, which once you're refractory, you're always gonna be refractory. And this can be leveraged more than once with BCMA target. Maybe preferable to go from CAR T to bispecific. We have data to show that it probably has better overall response compared to the other way around, but it's still acceptable. And short duration of response in one modality maybe encourages you to change to a different modality. However, we have a lot to learn about this. This is the IMWG Immune Therapy Committee recommendation, how to sequence the treatment. Post-BCMA CAR therapy, still BCMA and GPRC5D bispecific have effective responses, but maybe less durable, as we've mentioned earlier. And it mentions that the preference of CAR T over T-cell engagers whenever possible, but it's easily said than done. This is just a scheduling of a step-up dosing. I'm not going to go into, but it requires hospitalization initially for almost all these drugs. So infection risk is multitude of factors in bispecifics. There's patient-related issue with hypogammaglobulinemia. The diseases related issue with T-cell dysfunction leads to impaired cellular immunity, the CR risk that and related immunosuppressive supportive medication like steroids and tocilizumab increases your infection risk. And then, cumulative exposure, because bispecific is, a therapy until progression, and the more you're exposed, the more risk of infection. So this is the Saudi consensus for the recommendation of management infection in patients receiving therapy with bispecific. They recommend antivirals, IVIGs, PCP for PGP prophylaxis, and we have studies showing that IVIG use in those patients with immunoparesis using bispecifics really improves the outcome in terms of infections. This is comparing T-cell modalities with CAR-Ts and bispecific. I mean, it's clear bispecific off-the-shelf CAR-T requires hospitalization, it requires tertiary centers. CAR-Ts have a higher CRS rate in the initial period than done. One-time only treatment. Bispecific is a continuous treatment. So takeaways. Immune therapies have demonstrated impressive outcomes in those patients with relapsed refractory myeloma. It's one of the most landscape-changing treatment modalities. Those receiving the agents do have side effects that now manageable: CRS, ICANS, mostly grade 1, 2, and infections, which you have to be vigilant about with prophylaxis. You need to be aware of symptoms, especially when it comes to talquetamab and skin, hair, nail-related changes with supportive therapy as well. Bispecific, you benefit being off the shelf. A secondary hospital can use it, unlike CAR-T, which really requires, specialized centers. So I'm paving the way here for my colleague, Dr. Ines, to talk about our case, which is a pentaclass refractory case in Saudi Arabia, and it highlights the, the difficulty to access to clinical trials sometimes for those patients in here, and the newer FDA-approved meds are not readily available in time, as well as the financial toxicity, with all these therapies, and for the most part that our patients are still young at this stage. So here's Dr. Ines.
Okay. Thank you, Dr. Omar. A very thorough review of the bispecific antibodies. So now moving to real-world experience with a patient who have progressed on all these medications, and she reached to the stage that she needs the bispecific or the novel therapies. So at presentation in 2017, Mrs. D, she was a 38-year-old female. She presented with 2 years history of back pain, weight loss of 7 kilos, low appetite, and generalized fatigability, which is the common presentation for patients with myeloma. She was treated at several institutes and several primary dispensaries with muscle relaxants, painkiller. X-rays were never done. Eventually, she was admitted under thoracic surgery, where a biopsy was taken from one of the lytic lesions, confirmed the diagnosis of plasma cell infiltration and plasma cell myeloma. So the patient came to the clinic the first time. She was severely emaciated. She couldn't move. She was on a wheelchair. Mind you, she was only 38-year-old at that time. So these are her initial workup at presentation. Hemoglobin is 10.2. She was stage 3 by definition. And the cytogenetics at that time was 13q deletion, monosomy, but there was no P53. And you can see here in the table, she was mainly light chain component. So her kappa was 1,920 with a ratio of 179, so high disease burden, plus the amount of lytic lesions that were present in the scans. So at that time, she was diagnosed with stage 3, kappa light chain multiple myeloma. Back in the days in 2007, the treatment was completely different from what we're doing now. So the standard was the VRD, or the triplet regimen. So the patient was treated as a transplant eligible. Considering her young age, we were aiming to the most deep response possible. So she was started on VRD induction. In January 2018, she has completed 2 cycles with excellent clinical response. You can see, if you remember, the light chain ratio at the beginning was 175. It dropped down to 85. Then after another 2 cycles of VRD, unfortunately, there was a progression in the light chain. However, the kappa remained stable, so we elected to give another 2 cycles. Patient had a mixed response clinically, so we went to give her another 2 cycles of VRD, so she completed. Mind you, she was never collected because she had a high disease burden, so she was not collected at cycle 6. So moreover, she came to the clinic after cycle 6, feeling unwell, reporting similar symptoms that she had at the diagnosis. And you can see the light chain ratio was even higher from the diagnostic one. So the challenges here, she had an early progression, I would say relapse, because she had achieved some response over bortezomib and lenalidomide, which were the major treatment options at that time. There was no access to novel therapies. Carfilzomib was not available, only non-formulary, so the availability will take a while before we are able to start. And again, she was not collected. She was lucky. We were able to get carfilzomib on time, so she was salvaged with KPD, received 2 cycles, dramatic, excellent response. The one in the top is the recent one. So this is June, July. So she achieved complete biochemical response. That encouraged us to proceed with the stem cell collection. She collected successfully by GCSF and cyclophosphamide. We didn't have to give anything extra. And I just want you to remember the date of transplant was 26 September 2018, confirmed to have a complete response by bone marrow and by the light chain. And you can see complete normalization of the light chain. Post-auto stem cell transplant, she continued to be in remission. Now the challenge comes when we want to choose the maintenance, because she has progressed over lenalidomide, which was the first choice for all patients post-transplant. So access to carfilzomib was limited. We were able to get access only for the salvage. Pomalidomide was not approved as a maintenance, and she has progressed over bortezomib and lenalidomide. So we were thinking of a new target therapy. Of course, it will be off-label. So she was put on ixazomib maintenance, and she remained in remission. Unfortunately, in December 2020, 30 months post-auto, she presented to a dentist with pain in the mouth while chewing, and an examination, a bedside examination, revealed that she has a mass involving the right lower mandible. And this mass confirmed to be a plasma cell myeloma, so it's an extramedullary relapse, soft tissue extramedullary relapse. And these are her myeloma panel at the time of relapse. The light chain has risen again to, and also the kappa light chain. So this indicated to start, this was a clear indication to start third line treatment. So she had received bortezomib, lenalidomide, pomalidomide, and carfilzomib, and the most recent was ixazomib maintenance. So second auto stem cell transplant was not an option. The only remaining was daratumumab. It was not feasible to give her a single agent, considering her disease, early relapse, age, so many factors. So we give her a combination of DPD. At that time, DKD was only approved in 2020, so it was not an option to give as a salvage treatment or as a third-line treatment. So the patient responded very well. So the plan of DPD was mainly as a bridge or salvage in order for her to travel to do the CAR T-cell therapy. She went to USA, she got accepted, and she undergo lymphodepletion and received Apicma in December 2022, achieved complete response. There was no evidence of CRS or neurotoxicity whatsoever. She tolerated very well, did not require admission to ICU. And this is her PET-CT after CAR T-cell in USA in February 2023. She was feeling very well, complete biochemical response. However, the only thing that was concerning is the CT scan, the PET-CT scan in 2023, after CAR T-cell, like 2 months after, did show expansile mass that is new. So at their board discussion at that time, the decision was to go for palliative radiation. Patient was back in Saudi. You can see here the first evaluation in May, and then followed by another evaluation. This one, patient was completely asymptomatic, but her light chain, her light chain did show an evidence of biochemical relapse with a new FDG avid lesion in the left humerus. She was asymptomatic. We counseled her for salvage treatment. She completely rejected because she wanted to continue her treatment in USA. So until she came in August with severe shoulder pain, and you can see the progression of the lesion and the progression of light chain. So the options now in a 44-year-old triple class refractory, BCMA refractory, The remainings are the bispecific antibodies, teclistamab, talquetamab, and irlantamab, and I think Dr. Omar illustrated very thoroughly on all of these. So we elected to give her a new target because she had an early relapse post BCMA targeted CAR T cell. She was started on talquetamab, and now she's, as of this month, she is on ongoing treatment with talquetamab, 20 months. She has an excellent clinical response, quality of life, toxicity now 0, but at the beginning she did suffer with dysplasia, skin and nail discoloration, and actually she had a significant weight loss. But she's completely back to her normal life, she's back to work, barely any side effects, and only required palliative radiation to pre-existing bone lesions. So I hope this success story continue. Now, I'm sure all of you, the question comes to your mind, what if she progressed on talquetamab? And I think that's the end of my talk. Thank you.